Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
Welcome to Orthopedic Indications. If this is the first time joining us, my name is Nick Strasser, and today we have an alumnus of the program. We have Tom McDonald from Connecticut that's joining me. Welcome, Tom.
Hey, Nick, this is great. Thanks so much for doing this. It's a pleasure.
Yeah, well, it's always great to get on a call and chat. I mean, we've already been chatting for, I don't know, like 40 minutes already about what we're excited about. But I reached out because we have the upcoming annual meeting, and there's a lot of kind of exciting things to see as we're kind of getting towards Vancouver 2024. And you're going to be there. You're going to be there with a strong contingency from your own practice because you're partners with the president.
Yeah,
El Presidente.
being partners with the president is, a privilege and an experience. It is fun watching from the weeds, so to speak, and seeing him communicate on two different devices at once. And, you can imagine the influx of material that he's dealing with, and no one better suited for that. It's a pleasure and a privilege to be partners with Mike Aronow for sure.
Yeah, for sure. I could definitely see. It's probably nice though not to have like carry the weight of it and kind of get to
Just to be
at
next
least,
to it. Yeah,
yeah.
it's like being, I don't know what the parental equivalent is, being a grandparent or an uncle, maybe. That's a better analogy.
Probably the middle child is probably the more.
Better, yeah, he would say yes.
Well, so we have every year they have a guest nation, and I don't want to skip over that. So if you're going to be a vendor that's there this year, the guest nation is, or nations, I guess, is going to be Australia and New Zealand that are joining us.
The other AOFAS.
The other AOFAS,
Yeah,
yes. I think if you're listening to this and you're a vendor and you're going to be in the exhibitor area, they'll have booths there for their own organizations. So definitely check them out. We were chatting about some of the great things that's come out of there. We certainly talk about MIS and what Peter Lamb has done to help kind of push that forward. I think has been really great for our entire organization. I mean, there's so many talks. There's so many. If you go to like every booth that you're going to go to that deals with implants or instrumentation is going to have something to do or something to say about MIS.
yeah, for sure. I've only met Peter virtually on some MIS related Zoom calls, and just to listen to his very quiet, seasoned, experienced voice on all things MIS is both educational and soothing. And I look forward to, hopefully running into him. Really just, you and I were talking a little bit earlier. It's always great to see what drives technology evolution change, what drives evolution of thought process. I think any orthopedic foot and ankle society world round, what's that old expression? Pints a pound the world around. We're always dealing with the same clinical problems, but even in our own system, we see regional variances, sometimes based on our training or based on population demographics. How are we treating clinical problems, system problems? What are the pain points that Australia and New Zealand see in their daily clinical practices? I think, to some extent, progress is always dependent upon pain, and how do we recognize it, see it, treat it, and what are the kind of the influences that they are running up against or encountering, be it just access to care issues or access to technology, who's driving and funding the research that allows technology to change. And I'd love to hear Peter's perspective on that, and look forward to learning from them.
Yeah, definitely. And I think you would be a little bit shocked if you've only worked in the United States. I mean, I'm always surprised what we have and what's not available or is available in different countries. Think about that with Europe a lot. What instrumentation, you think about total ankles that were available there, or even Canada, it's just the access to some of the different technology is going to be different. So I think just stepping in and talking to them and getting to know them a little bit, I think would be pretty valuable for everybody. But that leads itself to MIS. I mean, MIS is, we think, here to stay. It's all the rage. It's very popular. I know you've dipped your toes in. I would say you've probably dipped your toes in more than most. You've
I
gone
might
in.
be up to my knees, but
You're tall, so that's pretty deep water.
Yeah, it's really been a journey and a relatively short one in my practice. I so appreciate the European experience and the Australian experience around that, who've been doing this for longer. I think, we have learned a lot, and I'm sure still have a lot to learn as we collaborate and fraternize and share experiences. And as the data from all of this experience starts to kind of roll out, I think there's a lot on the plate and a lot to learn from one another. And it's been interesting to see how quickly MIS forefoot technique starts to extrapolate into the midfoot, the hindfoot, and how if you do dip your toes or ankles or whole leg into the environment, how quickly just the philosophy behind it starts to change your clinical practice patterns. So it's been really fascinating to listen to experts who've been doing it for a decade or 2 decades, and to see how it's completely changed the way they treat, forefoot pathology. Really fascinating. And to see, you and I were talking about this a little bit earlier, like what drives that change? Is it the chicken or the egg? Is it us being creative around applying old techniques that we've been trained in, or is it technology offering us a new tool or a new implant that gets us to kind of reconsider and develop a technique around that? I'm not sure sometimes how we embrace change, if it's to what extent technology drives that or our society drives that.
Yeah, it's hard to know. I mean, I think that hopefully there's like a healthy balance between it, between innovation and the tools that you have available for you. But it's probably always going to shift one way or the other a little. But at the end of the day, I think it kind of works itself out that you have innovation and ideas and coming from surgeons and who see problems. And I think that's one of the things I've loved so much about the industry is I really do think they are partners with us on solving problems that are really challenging to treat. Taking a step back, saying like, how can we help? And I do think have made a difference for this. You think about MIS, and one of the challenges that has come up in terms of learning or adopting some of these new techniques is whether it's reproducibility or learning. There's definitely a learning curve there, and I think you're going to see a lot more jigs and tools out there to help facilitate osteotomies and some of the correction and then placement of the hardware. And I think it'll be definitely worth checking out at the different tables to see what's all out there and available for use.
Yeah, it really is a burgeoning field, and I think to your point, the jigs are kind of a gateway to reproducibility. That's really one of the fascinating and difficult challenges around minimally invasive technique, I think, is not only your individual learning curve that we all go through in the labs and by partnering with clinical mentors and having an alliance that you can really extract subtle technique from, but then also how do you teach it, right? How do you promote that? How does this get into our educational system? How do we give the pearls and the reins that we've acquired to our residents and our fellows? And I think as that starts, that kind of trickle down intellectual economics, as that starts to roll, I think that the adoption of MIS will really pick up speed and weight in our society.
Yeah, I think you talk about education and that's I think that is a pretty good gateway into some of the things that are happening. I think I chatted with some of the folks at Arthrex, for example, and they always do a great job with education, especially on site and having very good interactive times, down at their institution. They have state-of-the-art education, but they're now rolling out a 3D cadaver kind of module that you can use. And so something that you can really get in there, kind of get your hands on without getting your hands dirty, I guess. And yeah. I think just seeing all the different educational tools, I think Stryker is really trying to create didactics where they are really just trying to address the problem and help come up with algorithms for flat foot or total ankle and some of those challenges that they face. And so it's interesting to see some of the educational piece that I think really is trying to put the patient in the front, in spotlight, if you will, in terms of getting them a good result.
It's fascinating on that, just to riff on that a little bit, Nick, when we talk about some of the vendors out there rolling out printed technology, and a lot of the kind of the pre-op planning software is so powerful and kind of mind-bending to be able to segment and manipulate, midfoot and hindfoot models and really understand what our osteotomies are doing and what our deformity corrections are capable of, and being able to really unravel that and take that apart preoperatively is such a boon to then, how that translates on the day of the surgery and what we're able to do and how efficiently we're able to correct deformity.
Well, it kind of lends itself a little bit to some of the total ankle booths that are going to be out there for sure. I mean, Stryker obviously has the whole portfolio, but you're seeing other companies, whether it's Restore or Exact Tech, that are coming up with other, and if I'm forgetting some, please jump in, but are jumping up.
Locally here in my backyard, there's a company, Oxford Performance Materials, that is trying to promote its biopolymer and the technology around it, right? Again, the preoperative planning and kind of printing capability that comes with this. And I think as that, to your point, rolls into arthroplasty and being able to customize, shape, size, and orientation of implant. It's been around for a while, but it really seems to be launching into not only just arthroplasty, but osteotomies and, a segmental bone defect and complex fusions where we're trying to fill space and maintain length. I think it really starts to, just like MIS, starts to bleed into different aspects of what we do in our broad bandwidth of subspecialty.
Yeah, and MIS certainly blends in with a lot of that, where, and maybe this is taking a little bit of a step back to what we were talking about before, but yeah, I have to throw this out there because I'm going to give my resident credit. He says he feels like the MIS is the lightsaber of orthopedics, and can't remember which episode where I think it's like one of the very first, where he sticks the lightsaber and just like turns it around. He's like, that's what I feel like when we're doing the MIS cases. And so it sometimes it's what it feels like a little bit. You're like, I think I'm in the right plane or whatever. But Forma is a company that's developing some custom kind of guides for some of these things. We're taking some challenging problems like hammer toes and making guides and jigs, or MP arthroplasty. I mean, you and I have talked a little bit about that in previous conversations of the role of MIS and the MTP joint for fusions. And I said arthroplasty, but for arthrodesis, and being able to use that to help kind of customize the resection and making sure that it's spot on, and then being able to get it adequately prepped and prepared. So I think it's cool to see where they've kind of taken some new steps with this new technology.
Yeah, I think that's a great point, Nick. A lot of times I think, and tell me if you agree with this, there'll be an evolution of technique followed by an evolution of implant to make that technique easier, maybe followed by an evolution of instrumentation that always kind of lags, right? And so we're trying to do something through a smaller incision, and we're still using a Cobb elevator or, some old school instrument. So I think, Jigs, either through Forma or there's another vendor booth that specializes in instrumentation. I want to say it was maybe Buxton instrumentation.
Yeah.
I feel like sometimes those booths don't get a lot of play, but I think that's an area that's ripe for us to, focus on how can we take this new technique, be it minimally invasive or a new aspect of arthroplasty or deformity correction, and what do we need to manipulate or to preoperatively plan or to intraoperatively just make access more efficient. I think there's a lot of ground to cover there and progress to be made.
I think almost every vendor should visit Buxton because I bet they have some solutions for issues that come up for them in the OR that could be easily added to trays, and that would be a.
How often do you look on your back table and you're like, this has been here the whole time?
Yeah. It's like you read my mind. Yes, that happens all the time. Oh, man. Well, what about, curious on your thoughts of metal-free fixation? There's a couple companies out there. ConMed has a carbon fiber plate. Osseo has the bone screws, maybe for lack of a better term. There was the Ionomed, I think I said that right, that has Inion, I-N-I-O-N. And I'm sure there's others that I'm missing. What are your thoughts? Do you think that's a fad? Do you think that's something that patients will start asking specifically for that?
Well, let me just back up and joke with you a little bit and say that, for the audience, you created this incredible PowerPoint, or not PowerPoint, but spreadsheet of vendors A to Z. And I told you I got to F, so I can't help you on the Indian. But I'm so excited to do the loop and the lap a few times to find the Buxtons and to find, maybe the niche materials vendors that really represent the new frontier of how we're fixing and how we're thinking about constructs. And sometimes what's old is new again, right? I mean, bioabsorbable technology has been around for a while, and I think to that extent there's a little bit of barrier of entry that, or maybe burden of proof that these industries need to hold up for us, so that we can maybe overcome some old biases around older versions. And that's true for resurfacing and arthroplasty options, maybe around the MTP. You and I were talking about that a little bit. It's certainly true for metal-free fixation. Can you imagine where would we be in orthopedics without metal? And yet, there's an innate patient appeal. We run into that all the time. There's certainly a problem in foot and ankle orthopedics with removal of hardware, and that's an unnecessary burden for a lot of patients, where it's kind of we're constrained by the technology as we know it. And so I love exploring and really learning what the limitations are, right? Biomechanically and from a bioreactive standpoint, there's a lot to learn there. And I think a lot for them to prove.
We just went through kind of some of my sports partners have used, like specifically some of the osteo pins or screws for some of these subchondral, almost like a subchondral insufficiency fracture, like in the femoral condyle, to kind of basically provide like a rebar rafting. And it's interesting because, I've had a handful of patients that have had, you can see it on the talus, but even like the ones that are actually more problematic, but fortunately more rare are the tibial ones, where you get that kind of 30, 40-year-old patient that's got, maybe it's like early arthritis, but they're getting that bone reaction, edema, starting to develop a little bit of a cyst. And I think that's an interesting area to think about in terms of rafting or like a rebar kind of thing. I think they call it knee bar, actually. Knee-E-E-B-A-R-R. So that's we'll have to come up with something for the tibia, but it's an interesting area to kind of explore in terms of some of those things, or like intra-articular lesions, or it's like what options we have for fixing. Like some of those areas I think are troublesome sometimes for metal, or areas that you're never going to beat again, right? You have a talus fracture that you're through a medial malleolar fracture or osteotomy, and you don't want to go back to take out that screw, but I just experienced that wholeheartedly, where you're trying to take those screws out when you're doing the total, and there's no other way to get there. They're definitely in the way. So like I think thinking about it in some of those strategies could be really beneficial.
Yeah, totally agree. And I am a little esoteric in my kind of fibular fixation practice, having turned to intramedullary nailing for fibulas for a while, and a little bit of a sidebar commentary maybe, but just around the concept of having to take out hardware. And that's, for my practice, has been the game changer, just not doing removal of hardware for fibular fractures near as often as it used to be necessary. So I think that's a great point, to kind of be thinking about the downstream implications of our fixation choices.
I think there's definitely, you bring up a good point there. I was thinking about this earlier today, and I didn't write it down on our shared list, but like the fibular nails, there's now a lot more options. It seems I don't know if I want to use the word exploded, but not yet, but I can think of, let's see, we have Arthrex, we have Coventus, we have, I think Vilex has one now, we have the Acumed as the OG. And is there any other ones? Somebody will have to like reach out and slap me, but I
think that development is right around the corner. I think next year's conference will have a couple more.
I think
you're
right.
Sure of it. Proponents of that technique and technology would say, and good reason for it, right? I think just the fact that there used to be one and now there's four is telling. And I wouldn't call it a groundswell movement yet, but the fact that industry is responding to to that need or maybe to that want, I think is predictive of market share.
Yeah, I think you're right. And I think the one thing I'll say is, I don't know, definitely don't nail every fibula. I know there's been definitely a trend, or probably over the last maybe 6 months, and some of it has been in patients that I'm concerned about wound healing or implant difficulties. I can think of a gal who had a bleeding disorder and had another problem with a wound dehiscence somewhere else, and so I felt like that was a good indication for using something like this. Also, you have to get some experience with them, because you don't want to just use them one-off on some of these more, I don't want to say more challenging, because the fracture may not be that challenging, but you don't want to use it one-off. You want to make sure you get some reps with it beforehand. So I think getting some of the more straightforward patterns, I think has been actually helpful for me to kind of get some of the nuances down with the
Absolutely. Yeah. If the quote unquote perfect indication is a disaster fracture pattern or soft tissue envelope, it does taint your I guess attitude towards the implant, right? And I think some of the low energy elderly bimal equivalents or bimals are kind of begging for a really simple reduction and a really low profile, biologic friendly approach to fixation.
And you have to maintain length
on
those.
Don't get me on a rant, Nick.
Yeah, I know. Well, I was like, we're gonna go down this, and you have to maintain length. I think that's the one thing that is you have to be very cognizant of that. So my residents love it because they don't get to nail fibula anywhere else, and so then that obviously sways things a little bit. They're like, can we nail?
Yeah, for sure. But along those lines, right? Just who's the company? Ortho Solutions that has a unique twist on kind of posterior plating.
Yeah, absolutely.
Morphologies, and I think I don't know if you'd call it a new paradigm of thinking about how we fix posterior malfractures, but that's certainly been an evolution, led by Lyndon Mason and among others. Certainly he has all of my attention, and listening to him and learning from him and from his teachings has really shaped my practice. And I think, again, from that, industry will collaborate and respond to the pain point or to the problems that we encounter and develop new solutions. It's really a fun circle to watch develop.
I think I just listened because of his accent, because he's soothing. No, it's in all seriousness, everybody, I think it's a free download. His JBJS article, Mason and Posterior Malleolar Fractures, can't remember the exact title. That should be in your list of things to kind of hang on to, because not only do they go through a nice algorithm, it makes you understand and respect kind of where the patterns lie. And now when I take my residents through it, I tell them, like, when you're on call, look at every CT scan for all your posterior mals, and so many times they're seeing that tube. I think it's the 2B, that, and then I show them, okay, if you put this one first, and then you got to put this one next, and it's been really helpful for me. And I totally agree that's a really neat marriage, I guess, between innovation and I think patient improvement as well. It'll be interesting to see, kind of because he's talking a little bit more about this modified. I think we go modified posterior medial or medial posterior medial. I can't remember which one it is.
Modified, right?
Yeah, the modified posterior medial, and instead of the posterior lateral. And so I'm still I think we're all kind of figuring out what our algorithm exactly looks like in those cases. It really has, I think, got a lot of us rethinking posterior malfractures and how we want to approach them.